I'm Adisu Mesfin from the University of Rochester. It's my pleasure to introduce Dr. Lee Riley, who I trained under at Johns Hopkins. He is currently the Executive Vice Chair of the Orthopedic Department there, as well as a Chief Medical Officer of the Musculoskeletal Service Line. He'll be discussing with us the preoperative management of anxiety and depression in cervical spine patients.
Thanks, Adisu. These are my disclosures. So I want to talk to you first about the prevalence of anxiety and depression in our population. It is about 10% on a yearly basis for the general population, with a lifetime frequency of prevalence of up to 30 to 40%. It's about 3 to 5 times higher in spine patients. So it varies with the condition that they have. The depression prevalence is steadily rising, and this is a NIST study looking at ACDF patients. It showed a steady increase year over year of the rate of depression and anxiety in patients preoperatively. United States Preventive Task Force for looking at preventive medicine measures really felt that based on the frequency of depression and anxiety in the general population, the fact that most of it is moderate and severe and it has a significant impact on outcomes in general for healthcare, that a general screening of the population was recommended, and that in addition there needed to be a sufficient infrastructure to both make the diagnosis, treat, and then follow up patients. So in summary, anxiety and depression are common in our general population. It's even more prevalent and increasing in spine patients, and in particular in cervical spine patients. Treatment improves outcomes, and screening has been recommended as a first start for improving outcomes of patients who have depression and anxiety. The current literature on in cervical spine is very limited, and I just want to outline sort of the spectrum of the literature before giving you a summary of it. First of all, there are lots of data sets that are looked at, anything from the National Inpatient Survey or Market Scan administrative databases to case series to meta-analyses. The assessment tools are varied. They vary from sort of direct assessments for anxiety and depression that give you scales and actually can provide screening or diagnosis and severity to ones that are very, very rudimentary. The duration of time that patients have been identified as having anxiety and depression also varies from just in time, at the time of surgery, to up to 6 months ahead and several months afterwards. So there's a broad spectrum within the literature about what is anxiety and depression, how it's treated, and what its effects are. But there is a general consensus, and what that consensus says is that the patients who are anxious or have anxiety have worse outcomes. They report worse outcomes than other cohorts without it. They have higher complications, they have higher costs, but clinical improvement occurs even though it might occur from a different baseline, and that treatment improves outcome. So I want to look at first just one literature that shows that there's worse patient-reported outcomes in patients who have anxiety and depression. Dr. McDowell, who's following me, is one of the real content experts in this area, and she looked at a randomized control trial cohort of ACDF and disc replacement patients in a post hoc analysis. What she found and what they used was something called the Hospital Anxiety and Depression Scale, the HAD scale, which is a screening tool that asks 14 questions, 7 questions about anxiety, 7 questions about depression, scores each question from 0 to 3, and then gives a general score that then can be used to look at either high-risk or low-risk patients, with the cutoff being about a score of greater than or equal to 10. In this cohort, there was only a preoperative evaluation. There was no postoperative evaluation. But what they found was that in the high HAD scores patients, they had less improvement of their NDI and a less improvement of their VAS. Still significant improvement, not a reason not to offer patients surgery, but still not as they didn't do as well as patients that did not have depression. Complications were looked at in a large database of the New York State Planning and Research Committee of 20,000 patients. It was a retrospective review. It used ICD-9 codes. What they found in the nearly 5,000 patients that they looked at, with either depression and anxiety being the most prevalent diagnosis, was again a higher rate of device-related complications, infection, readmission, and revision surgery. And they again recommended a screening and support to complement surgery, not again to deny people surgery, but to help them through it and improve their outcomes. The long-term economic burdens and effect have also been studied with some market scan data. This was a group from Hopkins. They looked at anxiety and depression diagnoses using ICD-9 codes. They identified about 16,000 patients, 30% with depression, 25% with anxiety, and they matched the cohort. They found a greater likelihood of adverse outcomes, multi-day stays, 2-year revision rates, increased opioid consumption, and increased cumulative health care payments of about $6,000 for depression and $4,500 for anxiety. Again, quality of life. This was looked at in, again, a fairly small group that looked at pre-op predictors of change in the EQ-5D. What they found was greater depression led to lower quality of life post-operative improvement and less improvement with anxiolytic use and higher EQ-5D scores. Now, there are really only two papers that look at preoperative treatment of anxiety and depression. This is the one for depression. What they found was they found 25 patients and they pre-treated them and made the diagnosis of anxiety and depression by a psychiatrist, pre-treated them with medications and possibly also with therapy for greater than 6 months before surgery. And what they found was that they had similar baselines of patients with and without anxiety, and that their improvement was equivalent. So here it is here. You can see it's a small slide, but basically they acted as if their behavior, their reported outcomes were the same as non-anxious or non-depressed patients. Same thing with anxiety. These were patients who were treated with pharmacology for greater than 6 months pre-op, and they had post-op follow-up. What they found was, again, that there was significant actually improvement in pain scores in the treated patients and the untreated patients. So, preoperative anxiety, there were significant differences in post-op neck pain. It's unclear whether this is really an effect of treating the anxiety or just the medication itself that can lead to reduced pain. So in conclusions, pre-treatment of depressed patients with antidepressants improves their perception of pain and functional disability and improves outcome. Pre-treatment of anxious patients with pharmacologic agents improves post-operative neck pain and scores. What the literature doesn't really answer and what the questions it brings up is when should we treat and when should we really be looking at these patients and assessing them? Do we do this pre-op? Do we do it post-op? Do we do it both? How do we treat them? We really don't have any understanding of other forms of treatment, pharmacology, counseling, or motivational interviewing, and how long should they be treated either before or after surgery. So thank you.